Hey, welcome back. So now I have the right slide up, and as I mentioned here, the volume of distribution of digoxin is going to vary whether you have renal failure or not. If you have renal impairment, you're going to need to use a different volume of distribution than a normal volume of distribution. Notice here that the fraction unbound is 0.75, which means it's only 25% bound, which means it's not very highly bound to plasma proteins. When we think about that, and it is bound to albumin, when we think about that in relation to the 7 liters per kilogram, remember 7 liters per kilogram is a very large volume of distribution. A total body water is about 0.7 liters per kilogram, so it's 10 times larger than a normal volume of distribution, which means that relative to protein binding, there's going to be a lot more tissue binding. It's going to be much more highly bound to tissues, right, because it's stuck in that larger compartment. So it's not very highly bound in the plasma. It's relatively going to be much higher bound in the tissues, which makes sense, right? And that's why in renal failure, it's probably less bound to the tissues, so the volume is a little smaller in renal impairment than what you would expect, and that's what all this shenanigans is about. Now remember, when you have a large volume of distribution, it's going to dictate a longer half-life, isn't it? Because the larger the volume, the longer it's going to take for the drug to be able to get out of the body. So sure enough, we have a half-life of 36 hours. So we know we're going to be able to dose once a day, and we can even maybe dose less often than that. But that's not usually convenient for patients. But we know we can get away with a once-a-day dosing with this drug. As we would expect, if there's renal impairment, the half-life is going to be even longer, as you can see. And this is just a guess, And with hyperthyroidism, you haven't learned about thyroid yet, but most of you know it's sort of like a metabolism thing. So if you've got hyperthyroidism, you're going to be hypermetabolic, which means you're going to clear the drug faster than normal, and therefore will have a shorter half-life, but it's still once a day. All right, so we talked about clearance, we've talked about bioavailability, or clearance and volume and half-life, and whenever I talk about clearance and volume, you have to finish up with half-life there, right? The bioavailability of the drug is relatively high, as we would expect, because it's cleared by the kidney. It's not cleared by the liver. If it were cleared by the liver, then we would be concerned about maybe some first pass effect or something, but that's not the case here. We do see that we have between 0.7 and 0.9 on our bioavailability, depending upon the form that you're giving. Usually we give tablets, but it's only about 70% bioavailable if you give a tablet, which you're going to need to consider in your dosing, because if you want to give 100 milligrams of something and you give 100 milligrams of a tablet, it's only going to be 70 of it's going to actually make it into the bloodstream, right? So we have to consider that when we're doing our calculations. It's also a P-glycoprotein substrate. Remember that we talked about that with the kidneys, which we're not as sure what that means as we know what it means in the gut, right? It's an exocrine pump. So as we, if we enhance the P-glycoprotein, remember the P-glycoprotein is like a bouncer. So the drug gets absorbed through the gut wall, and then the bouncer is there to bounce it back into the gut so it doesn't get absorbed into the bloodstream. If we have a P-glycoprotein enhancer, we would expect the bioavailability to decrease, right? Because we've got more bouncers or more bouncer activity. If it's inhibited, we would expect the bioavailability to go up. You might have to think about that for a little bit. Also recall that there's enterohepatic recirculation with digoxin, which means that, like I said before, the drug is going to be spit back out into the gut. So you're going to see it again, and then it can get either reabsorbed or out in the feces. Therapeutic range we're shooting for depends upon what indication we're looking at. If you're trying to treat CHF, we want to have a relatively small, lower concentration. We're shooting for a lower therapeutic range of less than 0.8 Notice this, nanograms per ml, not our usual milligrams per ml, not even micrograms per ml, but nanograms per ml, itty bitty amounts, right? So CHF only needs an itty bitty amount to give your positive inotropic effect. This is not used as much as when we use it to protect the ventricles when we're treating AFib. Here we're shooting for a higher therapeutic range. Some people would push it all the way up to 2 nanograms per ml. And you're trying to ensure that those ventricles don't get going, right? That's the whole point of this. We initially target at the high end of the therapeutic range so that we make sure that we get those ventricles protected. So usually start at 1.2 nanograms per ml. Now, that depends. If you have an elderly patient or a patient with poor renal function, you might not be that aggressive because you'd be worried about DIG toxicity. So let's talk about DIG toxicity. What things do we see that are due to high levels of drug? Well, first we're going to see some GI effects, anorexia, nausea, vomiting, like we see with almost every other drug. So if you see this in a patient, you're probably not going to immediately think DIG. You're going to think, ooh, any drug. But DIG is pretty infamous for causing GI problems, even in the therapeutic range sometimes. So it's an early warning sign. It's a little bit of a canary in the mine for you. But it's hard to pick out because everything causes GI problems. CNS problems you can have with digoxin, headache, fatigue, insomnia, confusion, vertigo. A famous one for DIG are the visual complaints that patients will see. They'll see yellows and greens and halos around lights. And some people say, I don't know if you guys are familiar with Vincent van Gogh, or Van Gogh if you're Dutch. He's a Dutch impressionist painter, famous one, as I'm sure many of you have heard of him. If you can think of some of his paintings, Starry Night might be one that pops into your head, or some of the haystacks or the sunflowers, or he's the one that, cut off his ear and sent it to his lover or whatever. Anyway, some people say he had DIG toxicity. If you look at his paintings, you can see some halos and greens and yellows, but I think that's baloney, but it's sort of a fun little story to tell. Maybe it'll help you remember DIG toxicity. The one that probably makes the most sense that you shouldn't have to memorize is the cardiovascular problems, because remember, we're using this drug to slow the conduction through the AV node. So what would you expect to happen if you give too much? Too much slowing through the AV node, which would cause second or third degree block. You can also have AV dissociation, which means the atrium and ventricles are each doing their own thing. Bradycardia should have been listed first because that's what you'll see first. And I tell all my patients that I dispense DIG to take their pulse before they take their DIG every day. And that way you want to make sure, and it needs to be decided with their doctor, what their minimum pulse that's acceptable is before they take their DIG. So if their pulse is too low, they don't take their DIG and they call their doctor and let them know and ask them what to do from there. If you get these blocks, what can happen is the ventricles can take off on their own, causing premature ventricular contractions or ventricular tachycardia, which is what you're trying to avoid by giving this drug anyway. So obviously we don't want that to happen. There are lots of drug interactions with digoxin. These are all what I call bioavailability interactions, things that are going to affect bioavailability. This first one's pretty interesting. Eubacterium latem is a bacteria in the gut that's normally there that actually metabolizes digoxin. Cool, eh? So it decreases the bioavailability because it's metabolizing it in the gut before anything even happens. Erythromycin, clarithromycin, and tetracycline will kill this bacteria. So if you've got patients that are on these for treating infections, or a lot of people might be on them long term for acne, or acne is probably the most common thing, then they could wipe out this bacteria, therefore increasing the bioavailability of the drug because it's not there that normally would metabolize it. Interesting, eh? Aluminum-containing antacids, kalopectin, all adsorb digoxin. So does cholestyramine, used to decrease, to treat hypercholesterolemia. All will bind the DIG and decrease bioavailability. Sulfasalazine and neomycin also decrease bioavailability. Not sure why. Propanthyline will increase bioavailability because of an increase in the GI transit time that the drug itself causes. This is hardly ever given anymore. Metoclopramide and cisapride, spelling error, sorry, both decrease bioavailability because they decrease GI transit time. Drug interactions that change clearance. Quinidine was often given with digoxin because it treats that atrial arrhythmia that we see with AFib. Quinidine decreases renal clearance, decreases non-renal clearance, and decreases the volume of distribution of digoxin. We think it's a P-glycoprotein interaction in the kidney. Therefore, we see increases in digoxin by CSS average of digoxin by 30 to 70%. So that's pretty significant, right? Especially when we have such a small therapeutic window that we're shooting for with this drug to begin with. If you increase it by 30 to 70%, you're probably going into toxicity. Verapamil, diltiazem, and Bepredil, which all are calcium channel blockers, but notice it's not all the calcium channel blockers. It's the ones that slow the conduction through the AV node. So remember, these are doing the same thing that DIG is. So first of all, you've got a problem with additive actions, although maybe you want that, but still remember these drugs also will decrease the clearance of digoxin, increasing its CSS average. So not only will you have the added pharmacologic effects of these drugs, but it will increase the CSS average of the DIG. So you might get more slowing of the conduction than you really intend when you add in these calcium channel blockers. Amiodarone is another one that's commonly used to treat chronic AFib. So again, you have to be super careful because it decreases the clearance of DIG and increases the bioavailability. You see 2 to 3 times increase in CSS average. So not a percentage, but this would be 200 to 300 times increase, or not 200, 300%, right? Not times. So if the concentration was 1, it's now going to be 2 or 3, which would be toxic. 1 is at the lower end of the therapeutic range to treat AFib, isn't it? So this is a very critical drug interaction. Make sure you know all 3 of these without fail, because they're often given together. Propafenone also can be given with DIG. It will decrease its clearance, increasing the CSS average by 30 to 60%. Cyclosporin is not as often given with DIG. It is a anti-rejection drug. It's an immunosuppressant that's used for many things now, but it increases the CSS average up to 50%. Also probably a P-glycoprotein interaction. All right, that's it for DIG. So now we're going to do some problems. Thanks. Bye.